Bald tongue with loss of papillae. It is seen in anemia and particularly in vitamin B complex deficiencies. Treat it with vitamin B complex injections and tablets plus hematinics. A bald and bright red tongue is seen in niacin, that is B6 deficiency. The bald tongue with loss of papillae due to B complex deficiency. Here note the black pigmentation of the tongue, very common in our population, and it is of no particular significance. Note the irregular black pigmentation over this tongue. Prominent papillae and excessive furring is also seen in varied conditions like mouth breathing, smoking, dyspepsia, constipation, chronic fevers, etc. So overall it is a non-specific finding, mainly suggesting digestive disturbances. Watch the prominent papillae of this tongue. A fissured tongue with deep furrows is also of no particular clinical significance. Only if the furrows are painful, treat them with high doses of vitamin B complex. Now see this geographic tongue with irregular bald patches. The pattern of these patches may not be constant and may change with time. It's of no significance, and giving B complex supplements is not going to make any change in this patient. Just reassure the patient and leave him alone. Aphthous ulcers. This is one of the commonest conditions seen in general practice, where a patient complains of burning and pain on eating chilies, and there are one or more tiny inflamed ulcers over the tongue or buccal mucosa. They are treated with high doses of vitamin B complex. Locally, apply a soothing lotion like glycerin borax or anesthetic preparation like xylocaine ointment or Zyte lotion. The aphthous ulcers, as seen on the lateral margin of the tongue, are self-limiting and heal within a week, but they tend to recur. If an ulcer persists for more than 2 weeks, then malignancy should be kept in mind. See the multiple aphthous ulcers on this tongue, and see the large ulcer on the undersurface of this tongue. If an ulcer is large and hard, it should be biopsied. Leukoplakia. When there is a white patch on the tongue or cheek, what we term as leukoplakia, you should be aware that it is a precancerous condition, and this tongue does show a suspicious lesion in the proximal end of the white leukoplakic patch. Leukoplakia is common in our population, where chewing tobacco is a very common practice, and its serious significance should be kept in mind. Note this case of suspected carcinoma of tongue. Note the everted margins of the growth suggestive of malignancy. There is no ulceration, but we must palpate the tongue for induration, and if the base is firm to hard, then the patient must be referred for biopsy. Again, a typical case of carcinoma of the right tongue margin. Note that it is raised above the tongue surface and the base was very hard to palpation. Now here we see a white patch of leukoplakia on the inner mucosa of the cheek. This needs to be biopsied and when possible excised, even if it is not malignant. because the risk of malignant change is very high. Leukoplakia is a very common finding in pan eaters. Look at the typical tiny aphthous ulcer on the inner surface of the lip mucosa. Just as over the tongue, aphthous ulcers are common over the buccal mucosa. They are treated with high doses of vitamin B complex, local glycerin borax or xylocaine ointment, and if they are recurrent or multiple, a course of Flagyl and antifungal nystatin lotion. Here we see a case of acute tonsillitis with inflammation of the tonsils, and pus is seen through the tonsillar crypts. Acute tonsillitis is treated with steam inhalations, salt water gargles, an antibiotic, and aspirin or any anti-inflammatory drug. Once the acute attack subsides, tonsillectomy may be advised if the attacks are severe or recurrent. Acute follicular tonsillitis. A white patch or slough on the tonsils or pharynx should make you alert about diphtheria, which luckily is quite uncommon today due to immunization programs. Such patches are seen in the tonsillar fossa in the week following tonsillectomy, and that is normal. But when diphtheria is suspected, refer the patient to a hospital for throat swab study and treatment. A white patch in the throat, especially in children, should be investigated for diphtheria. Following broad spectrum antibiotics, especially in diabetics, there may be fungal superinfection of the buccal mucosa, giving rise to oral candidiasis with multiple white coated patches in the mouth. Note the white patches on the palate of this patient. It is treated with local nystatin solution and oral antifungal drugs, along with the control of diabetes if present. There is a malignant growth over the cheek, which should be immediately referred to a surgeon. Note the raised and fleshy growth over the mucosa of the inner surface of the cheek, which is protruding at the angle of the mouth. It was firm to hard to palpate, and as we will now see, the submandibular lymph node was also enlarged and hard. All definite signs of malignancy. I will stress here again that whenever malignancy is suspected, always palpate for regional lymph nodes. This is a mucus cyst, a simple cyst on the inner aspect of the lip which is harmless, but it ruptures and recurs, and it has to be excised. Excision is done under local anesthesia, for which the patient should be referred to a surgeon. A simple mucus cyst of the lips. Note the hypertrophy of the gums. Patients on phenytoin sodium therapy for epilepsy commonly get it if dental hygiene is not maintained properly. If the hypertrophy is excessive, the hypertrophied portion is excised by gingivectomy. The best way to prevent it is by maintaining proper dental hygiene. So you must give these instructions to your epileptic patients who are put on phenytoin therapy. Here is another epileptic patient on phenytoin sodium therapy with mild hypertrophy of the gums and poor dental hygiene. Now we will look at the face. A puffy face should make you think of three common conditions: renal edema, myxedema, and steroid faces. Notice the typical renal edema, maximum around the eyes, more in the mornings in a case of nephrotic syndrome. If it is of sudden onset with scanty red urine, think of acute glomerulonephritis. See the distribution of edema, which is mainly in the loose tissues of the face with minimal dependent edema of the legs. Notice the myxedema face. Note the dull look on the face. And though we cannot hear her hoarse and slow voice in this cassette, I will demonstrate the slow relaxation of the ankle jerk, which is as confirmatory of myxedema as the costly T3, T4, TSH studies. See how slowly the muscle relaxes. 100% diagnostic of myxedema. This is another patient of hypothyroidism. Though it is uncommon in males, that dull look in the eyes is characteristic. Steroid face is also similar and should be thought of if the patient is on steroids, say for bronchial asthma or some skin disease. This is Rhizus sardonicus of tetanus. It gives an appearance of laughing due to contraction of the facial muscles. I will demonstrate the other signs of tetanus also. I am asking her to open her mouth, but she can't. She has lockjaw. Lockjaw is the earliest sign of tetanus. See the neck stiffness. See the stiffness of the muscles of the hands. So in every case of muscle stiffness, lockjaw and convulsions, keep in mind tetanus. See the stiffness of the legs. And see that even the abdominal muscles are stiff. Bell's palsy or facial nerve palsy. A healthy person suddenly finds on waking up one day that the mouth is deformed and one eye is not closing. See the absence of wrinkles on the left side of forehead on looking up. Ask the patient to close the eyes and note the turning up of the eyeball on closing the eyes, termed as Bell's sign. Tell the patient to smile and the affected angle of the mouth does not move. Let him blow up his cheeks and air leaks through the left angle of mouth. This is left facial palsy. If this patient has pain or some pathology in the ear, refer the patient to an ENT surgeon. Otherwise, treat him with high doses of vitamin Bplex and steroids for 2 to 3 weeks. Parotid swellings are also often seen in practice. Mumps is very common in children with diffuse swelling of both parotids, which needs only symptomatic treatment. Benign mixed parotid tumors such as these are seen to be present under the ear lobule for several years. If the swelling raises the ear lobule, it is definitely arising from the parotid gland. When parotid swelling is present, also look for facial palsy, and the patient must be referred for surgery, especially if the swelling is long-standing, large, nodular or adherent. See a large and nodular parotid tumor in this old man. Malignancy must be ruled out. Now we shall see a few orthopedic conditions. Rheumatoid arthritis. This is a typical hand of rheumatoid arthritis. Note the deformity of the small joints of the fingers. Whenever multiple joints are affected, especially small joints of fingers and toes, think of rheumatoid arthritis. Note the deformity of interphalangeal and metatarsophalangeal joints. In this patient, the wrists and the feet are also markedly affected. Rheumatoid arthritis is characterized by pain, swelling and stiffness of multiple small joints along with systemic features like anemia, weight loss, fever and rheumatic nodules. Tetany. This is a typical position of fingers in tetany. The patient also gets severe cramps in the forearm muscles and hands. It is primarily due to calcium deficiency. So give intravenous calcium gluconate followed by oral calcium supplements. Note this swollen right knee. This particular boy was a hemophilic who has got hemarthrosis following a trivial injury. But normally hemarthrosis may occur following an injury with a fracture or ligament tear, and you should ask for an X-ray. If this picture was seen with no history of trauma but tenderness, warmth and fever, then I would have suspected an acute pyogenic arthritis or rheumatic arthritis. And if the quadriceps, that is the thigh, was wasted and thin, I would have thought of tuberculous arthritis. In this patient, note the prominence of T10 vertebra. Tenderness and gibbous are typical of tuberculosis of spine. In a patient who has fallen from height, such a gibbous will indicate a compression fracture of the spine. If a patient with gibbous has weakness of legs, then he should be referred to an orthopedic surgeon urgently. This is kyphoscoliosis. Such extensive deformities are usually congenital. But if it is of recent onset or if it is increasing, then refer the patient to an orthopedic surgeon. Now I will demonstrate some neurological signs. Exaggerated jerks. We have already seen delayed relaxation of tendon jerk in myxedema. See it again. See the slow relaxation phase. Now compare it with a brisk and exaggerated tendon jerk. This is typical in upper motor neuron type of paralysis. Watch the exaggerated ankle jerk. Exaggerated ankle jerk may also be demonstrated through ankle clonus. Sustained dorsiflexion of the foot results in ankle clonus, that is a repetitive rhythmic contraction of the calf muscles, recurring for as long as the pressure is maintained on the sole of the foot. Upper motor neuron lesions also show extensor plantars, that is positive Babinski reflex. It is demonstrated by stimulation of the sole along the lateral border from the heel towards the toes. This normally causes plantar flexion of the soles, but as you can see here,